Okay, Kayley Scott, Institute of Cardiovascular Medical Sciences, University of Glasgow. Magnesium sulphate treatment during hypertensive pregnancy improves maternal but not fetal outcomes in rats. So that's very interesting. I gave a talk about that to a recording device this morning, actually. Something a bit like that. Anyway, so Kayley, welcome to Sharp. You've got about 8 minutes and look forward to it. Off you go.
Thank you very much.
Thank you.
Oh. Well, good afternoon, everyone. Thank you very much for having me. It's nice to be a basic researcher at a clinical meeting, so hopefully you follow along with everything. But today I just want to talk to you about what I've been working on, which, as we said, is that magnesium sulphate looking at pregnancy in rats. So hypertensive disorders of pregnancy then, they can be divided into 4 distinct categories. So we have gestational hypertension and preeclampsia that occur after 20 weeks or more of gestation. And we have chronic hypertension with pregnancy. So that's a pregnancy where the chronic hypertension is pre-existing before they become pregnant. And we also have preeclampsia superimposed on chronic hypertension. So that's when that chronically hypertensive pregnancy progresses even further into a preeclamptic phenotype. And as you might guess, they are all classified by varying severities of high blood pressure. Preeclampsia itself is additionally defined by a new or worsening proteinuria at those 20 weeks or more of gestation. And in some patients, this can actually develop even further into sudden onset grand mal seizures, which we know as eclampsia. Now, eclampsia at the moment, as far as I'm aware, the clinical intervention is magnesium sulphate, which has been shown in several studies to reduce the occurrence of stillbirth. So it is the accepted treatment at the moment. Now, the hypertensive disorders of pregnancy are increasing in prevalence worldwide, and this is in part due to lifestyle changes in women of childbearing age. Now, due to their multi-organ effects, they can not only impact the maternal system, so things like damage to the heart, damage to the kidney and the blood vessels, but they can also directly cause fetal growth restriction. And in both mothers and offspring that are affected by these conditions, the increased risk of cardiovascular disease is significantly raised in both. However, our understanding of the underlying pathophysiology of these disorders is currently very limited, and our current clinical interventions can only manage symptoms but not actually treat the disease. However, this unmet need can be resolved using animal models, and that's where my lab and my research come in. So in our lab, we focus on the stroke-prone spontaneously hypertensive rat, or the SHRSP, which is a strain of rat that's bred with a genetic predisposition towards high blood pressure, hypertension. Now, if you look up in the figure, I don't know if I can, I can get my little mouse up. When we compare it to a normal tensive strain, the Whistler Coyote WKY across a pregnancy, we can see that the SHRSP have this chronically elevated hypertension that persists through the whole gestation. And they also see in these histology images, they have defective vascular remodeling, which reduces the lumen of their vessels, which is very similar to what we see in humans affected by these conditions. Now, in the SHRSP in particular, it's a model of chronic hypertension during pregnancy that when we administer angiotensin II can be stressed to develop superimposed preeclampsia, and that's what I'll be focusing on today. So just to run you through the methods of my study, we've recruited female SHRSP rats and took baseline pre-pregnancy measurements before we mated them and confirmed the mating. And then throughout the pregnancy, at 3 different gestational time points, we did analysis using echocardiography, metabolic cages, which we used to collect urine and water intake data, and we also measured the systolic blood pressure. Very importantly, on gestational day 10, as that's the day of placental development in rats, we implanted those osmotic mini pumps that were delivering either 0.9% saline, so a sham group, or the angiotensin II to develop that superimposed preeclampsia Ang2 group. Now, a couple of those animals receiving Ang2 were also given 1% magnesium sulphate in their drinking water every day to assess the effects of magnesium sulphate on outcomes, as we know that magnesium can improve endothelial function. At the time of sacrifice, we then took all the fetuses and the placentas and used them to measure fetal and placental growth. So on to the results then. The first thing we noticed that was when we gave the angiotensin II, so that superimposed preeclamptic treatment, we found significant drop in maternal weight gain and significantly elevated maternal systolic blood pressure, again as you would normally see in the human condition. And when we add that magnesium sulphate treatment, we're seeing a significant increase in maternal weight gain back towards those sham levels. And as we move along late gestation in this dashed line, we see that magnesium sulphate is also causing this lovely significant drop in systolic blood pressure in late pregnancy, right back almost towards those sham levels. So it seems that the magnesium is doing some good things for maternal weight and maternal blood pressure. We also wanted to look at fluid homeostasis with those metabolic ages, and we found that when we gave the angiotensin II treatment across pregnancy and in late pregnancy there was a significant increase in both water intake and urine output, which suggested that giving these rats that superimposed PE altered their fluid homeostasis. But we were able to reverse that by giving that magnesium sulphate treatment, significantly lowering both of those back down towards their sham levels. So again, seeming to improve fluid homeostasis. We also used echocardiography and ultrasound to look at cardiac function. And we saw in the ANG2 group that across pregnancy there was this gradual increase in relative wall thickness. However, this was significantly raised when compared to sham when we gave the magnesium sulphate treatment. When we looked at stroke volume in the late pregnancy, that ANG2 treatment, so that PE treatment, significantly decreased stroke volume, but we weren't able to rescue that phenotype by giving the magnesium sulphate treatment. However, there's a possible silver lining, because when we looked at the changes in cardiac output as a reference to their pre-pregnancy baseline, when we look at the magnesium sulphate group, we see that there seems to be this positive trend throughout pregnancy for an increase in cardiac output. And that's something we don't see in either the sham or the ANG2 groups. As you can see in mid-pregnancy, they're both showing a negative change. So it seems there may be some effect, but we would need further work to fully understand what's going on there. Now, as I said, we thought that magnesium might have a beneficial effect in the vasculature because of that nitric oxide production it's known to induce. However, we saw absolutely no effect of either our ANG2 treatment or the magnesium sulphate on top on indices of uterine placental flow. However, it is worth noting that our sham mothers are already chronically hypertensive and already have placental vascular dysfunction, and that may explain the lack of effect we saw in both of our treatments. And finally, looking at the fetal growth, we found that when we induced that preeclampsia, we had significant drops in both fetal weight and placental weight in those ANG2 groups. However, when we gave magnesium sulphate on top of that, it was actually even worse, causing further significant drops in fetal and placental weights, as you can see here, and also an increase in something called the head-to-body ratio, which is an indicator of head-sparing fetal growth restriction. So it doesn't seem to be looking too good on the fetal side. So to just summarise and conclude what I've shown you today then, we found that administration of our angiotensin II significantly impacted maternal cardiovascular function and fetal growth during pregnancy. Treatment with 1% magnesium sulphate water was able to significantly improve maternal weight gain and systolic blood pressure throughout pregnancy and improve fluid homeostasis in late pregnancy. There was evidence to suggest the magnesium sulphate may have positive effect on maternal left cardiac function in the model. However, more in numbers and further work is required to understand that effect. And despite its vascular actions, it didn't improve uterine blood flow or fetal development. So the data shows that it may be beneficial for maternal but not fetal outcomes in this model, but we need further work. Thank you very much, and I'll happily take questions.
Kayley, thank you very much. Now, questions from the audience. Kayley, what does it tell us about the use of magnesium in preeclampsia in women, do you think? Or is that too early to add a question to address?
I think, so could you possibly rephrase that?
Yeah, I mean, what you've shown us here is that magnesium sulphate didn't protect in any way the development of the rat fetus. Mm-hmm. Now, what we know in eclampsia in women is that while you might treat the blood pressure, in fact, the placental damage is ongoing. And I think that your research might support that. What do you think about that? That your research gives us more belief that it's not just about blood pressure, it's about placental dysfunction in preeclampsia.
definitely. I highly agree with that point, and I think it's actually more beneficial to focus on the placental dysfunction rather than the blood pressure, because we've actually shown in some of our previous work you can lower blood pressure through various agents, but again, you still don't get that effect on your placental flow.
Yeah. Question here. Carl, Cambridge.
Hi.
Carl, thank you.
Excellent question. So unfortunately I couldn't show you all of our data here today, but we are able to recapture the systolic blood pressure changes, that defective vascular remodeling, as well as the changes in kidney function, so albumin creatinine ratio and things like this as well. So I would say it's pretty close, but definitely not a perfect recapitulation, which of course no animal model could be. Yeah.
Thank you. If an SHR gets pregnant twice, do they get eclampsia more the second pregnancy or first pregnancy? And then Professor McCrae, then honourable.
So, great question. I actually don't know. I've only ever studied singleton pregnancies in these animals, but it's definitely something I would want to look into, as well as future risk. Yeah.
Okay. Professor McCrae, last question.
Just a quick follow-up on Carmen's question. If in a non-spontaneously hypertensive rat you give angiotensin, does magnesium have the same effect on the blood pressure phenotype?
There's a similar effect on blood pressure phenotype, but we're not able to really give the angiotensin 2 because we have had significant effects to welfare, so the animals tend to die off before we can finish the study. So honestly, not something I've looked too much into, but definitely something I will do from now. Thank you.
Well, Kayley, thank you very much.
Thank you.
Good. Thank you.